Dr. Craig-Schapiro. I'm one of the transplant surgeons here at Cornell, and we're going to talk today about extended criteria donors, or ECD. So what we'll discuss today is what is a standard criteria donor, and then what is an extended criteria donor. How do we evaluate donors? Who decides if an extended criteria donor is right for me? And what do I hear when I'm called in for a transplant? And am I penalized for saying no? So while we may wish that all organs were factory fresh and brand new, that's not the case. We don't have manufactured organs, so it's not like a hip replacement or a knee replacement where you can get something off of the shelf. We have to keep in mind that organs come from real people who have died, and they have a history, and they have a history of medical problems. So to be able to donate, donors are diagnosed with brain death. And what brain death means is it's a permanent diagnosis. And brain death means that there's irreversible loss of function of the brain. A diagnosis of brain death is made by a careful neurologic examination, by demonstrating loss of blood flow to the brain, and or loss of electrical activity can also confirm. Although these donors are brain dead, we can use equipment like ventilators and things like that to help keep flow to the other organs, including the liver, for hours so that they're able to donate. In general, some of the common reasons that people suffer brain death is that they can have had a stroke, they could have had bleeding in their brain, maybe from a ruptured aneurysm, trauma to their head, or inadequate oxygen, which is what we see when individuals die from drug overdoses. It's important to remember that this is different than a coma, which is not permanent, and different than vegetative state, in which they're not brain dead. So in brain death, they have complete loss of their brain function. So when we talk about standard criteria donors, what we're talking about generally is we're talking about brain dead donors. They're generally under the age of 65. They've been tested for HIV, hepatitis C, and hepatitis B, and we know that they're negative. And we get from their family an extensive history of all of their medications, prior hospitalizations, surgeries, travel, all kinds of history about them so that we can understand them a little bit more. So I'm going to shift topics for a second, and we're going to talk about what are the 1-year outcomes. So 1 year after you've been put on the list for a liver transplant in our region, meaning New York. Okay. So as you all probably know, that livers are allocated in the United States by the MELD system, and your MELD is calculated based on your lab values. And so just like your lab values change, your MELD score changes. And MELD goes all the way up to a score of 40. So if you're a MELD 40, you're pretty sick. Generally, you're in the hospital. And we know that the average MELD that people get transplanted in New York is around 31. So let's look at a group of people that are MELD 15 to 24, so kind of middle of the road MELDs, and we're saying any blood type. And what happens 1 year after they've been put on the list for a liver transplant? Well, 55% of them are still waiting for a liver transplant. 20% have either died during that year or have become too sick to receive a liver transplant. And 15% have actually undergone a liver transplant. Now, I'm sure you know that there's different blood groups, and the blood groups matter. And so let's look at this when we look at the different blood groups. So let's say you're a blood type O, which is the most common blood type. And then let's say we're looking at a MELD 25 to 29. So a little bit higher MELD, but still kind of middle of the road MELD. 1 year after going on the list for a liver transplant, about 37% either have died or have become too sick for a transplant. 18% are still waiting, and a third of patients have been transplanted. And we see similar trends if we look at the other blood groups. So this is blood type O. But if we look at blood type A, we see something similar where at 1 year, 60% are still waiting for a transplant and 10% have been transplanted. And if we look at blood type B, again with this kind of middle of the road meld, at 1 year, we see that 15% have been transplanted, 50% are still waiting for a transplant, and about 20% have either become too sick or have passed away. Blood type AB is a little bit different because it's a very uncommon blood type, and so they have better access to organs. So at 1 year, 60% of these individuals have been transplanted. So you might say, looking at these numbers, well, how am I ever going to get a transplant? And so that's where I think it's important to talk about and understand what extended criteria donors mean, because this is a way that we can sometimes get you a transplant. So there's no set criteria for what an extended criteria donor means. The criteria vary amongst programs, but they're generally pretty similar. And generally it refers to donors that are older, donors that may have some fat in their liver, donors with what we call some increased risk behaviors, donors that have been exposed to hepatitis, and donors after cardiac death instead of after brain death. And we're going to go over what each one of these things means a little bit more. So when we talk about age, we think that there's actually no limit on the natural lifespan of the human liver, as opposed to other organs that definitely age, like the heart and the kidneys. We think that livers from older donors can be used quite well. Now, they do have a slightly higher risk for poor early function. So what that means is that after the transplant, it might take a little bit longer for your lab values, for your liver enzymes to come down. But we know that carefully selected livers from older donors function just as well as livers from younger donors. And importantly, they have similar long-term outcomes. So this has both been studied through national data, OPTN data, as well as we studied it here at Cornell and published on it, that the outcomes long-term from these older donors can be just as good as the outcomes from younger donors, as long as they're very carefully selected, okay? Now, talking about fat in the liver. So it's very common that you may hear that people have some fat in their liver, very common, especially in North America, and it doesn't affect most people. So you have some fat in your liver, but it doesn't cause you any harm. And so we know that if there's a little bit of fat in the donor's liver, it can, again, take a little bit longer time for those liver enzymes, those liver lab values to come down to normal after transplant. But there's no known long-term effects on your outcome. So if the liver has a little bit of fat, now there's varying degrees of fat. If there's a lot of fat, we won't use that liver. But if there's a little bit of fat, we know that these livers can work really well. It just might take a little bit longer for your lab values to become normalized at the beginning. So this is another source of these extended criteria donor livers. Another category is these individuals that have what we called increased risk from their social behaviors. So it's not due to their medical history, it's due to some of their social history. And things in this category would include individuals that have used IV drugs, if they've been incarcerated, certain sexual practices, if they've previously had hemodialysis or lots of blood transfusions, or if we just don't know anything about the donor. So these criteria were established a really long time ago. They were established over 20 years ago. And these criteria were established because there was thought that there's an increased risk of infection in donors that have some of these behaviors. But things have changed in the last 20 years, and we've had significant advances in our testing. So we're much better able to test for hepatitis C, hepatitis B, HIV. So this has really reduced this risk. So the chance now of a donor that tests negative for HIV or hepatitis C, but actually having that, is significantly less than 1%. It's 0.0003%. And so these criteria are a little bit, I think, out of the times, but it is something to be aware of. Remember that no matter what the history is of the donor, no matter whether it's a standard criteria donor or an extended criteria donor, all donors are tested for HIV, hepatitis C, and hepatitis B. And the small risk of getting an infection from these donors, that 0.0003 risk, is significantly less than the risk that you've seen in the previous slides of either dying while waiting for the liver transplant or becoming too sick. So donors that we know have hepatitis C, so they've tested positive for hepatitis C, we used to say that we could only give their organs to a recipient that also had hepatitis C, but that's not true anymore. And that's because we have new drugs that can cure hepatitis C. And so now, thankfully, we're able to use livers and kidneys and hearts and from individuals that have hepatitis C and give them to individuals that don't have hepatitis C. And that's because of these new drugs that have very high cure rates of greater than 99%. So what it means is if you get a liver from somebody that has hepatitis C, then you have to take an extra pill after the transplant every day for 8 to 12 weeks, and then that cures the hepatitis C. Likewise, donors that have been exposed to hepatitis B, they can also be excellent donors. They can have otherwise very healthy livers. And what that means is that after transplant, you'll have to take an additional pill every day for the rest of your life to help prevent hepatitis B from developing. And then I briefly mentioned donation after cardiac death. So this is different than donation after brain death. These individuals do not meet the really strict criteria for brain death. And so what happens in these donors is that they have withdrawal of life support, and then if they pass away, their organs are able to be donated. And so during this time, their heart and their blood flow stops for a few minutes before they're able to donate their organs. And so that results in an increased risk of slow early function. So the same thing that when we talked about the older donors or the donors with a little bit of fat in their liver, a similar thing that your lab values may take a little bit longer to come down after the transplant. And then there's one additional complication of a cardiac death donor that should be mentioned, which is that one of the connections that we make between the liver and yourself, which is the bile duct, can have some increased risk of narrowing with this type of donor. So that's something that's important to talk to us about when we're considering one of these livers. So who decides if you should receive an extended criteria donor? Well, it's a team decision. It's your decision and our team in combination, because we want everybody to be comfortable with this decision and feel that it's the best decision for you. So we also want you to discuss it with your family as well and discuss with them the risks of waiting on the list versus the risks of an extended criteria donor. And then we have forms for you to sign. So what happens when you're called in for a transplant? So when you get that phone call, it'll come from one of the surgeons, and you'll only get the phone call if we think that liver is good for you. So if we don't think the liver is good for you, we're not going to call you and tell you about it. We're going to tell you when it's a good liver. The things that we'll tell you is about the donor's age, their general cause of death. If it's an extended criteria donor, we'll tell you why it's extended criteria donor and kind of what we assess that risk to be. The things that we won't tell you is things that would identify the donor. Okay, so we have to maintain the donor's privacy. So things like their location or identifying details we cannot share with you. So a few last points about extended criteria donors. About half of the organs that are used, both here at Cornell and in the whole nation, meet one of these criteria. So this is not a rare thing. About half of donors are extended criteria donors. They enable you to get a transplantation faster rather than waiting for your MELD to go up and waiting for you to get sick. There's a slight increase of delayed working at the beginning. So usually in the first week or so, it might take longer for your lab values to start coming down. And I think it's important to remember that it may not be for everyone. So if you're on medications that are controlling your symptoms very well, you might not want to take the risk of an extended criteria donor. Or if you have a living donor, or if you have a clear path to transplant. So that would be somebody that's blood group AB that we talked about, how they have this advantage to organ access, or if you're somebody that has hepatocellular carcinoma or cancer points. So in conclusions, the extended criteria donors may lower your risk of dying before getting a transplant by allowing you to get to transplant sooner. You should discuss this option with the rest of your family. And then when you're called in for an organ offer, just keep in mind that when you get that phone call, you'll only have a short time to decide at that point. So you should have already thought about these things in advance so that you have a sense of what you might answer when you get that phone call. Okay, I'm going to stop sharing my screen and see if anybody has any questions.